All right, welcome back to ABA exam review and the continuation of our RBT practice questions series, where we're going through another set of questions together and breaking them down. If you're new to the channel, welcome. If you're returning, welcome back. Please like and subscribe. Check out btexamreview.com for all of our study materials, including our combo pack. When you pass your exam, let us know so we can include you in the Sunday shout-out. Work hard, study hard. Let's get going. Your client consistently shows signs of fatigue during the last 30 minutes of 2-hour sessions. Increased errors, slower responding, and mild problem behaviors. The current schedule is based on insurance authorization. What's your most appropriate course of action? So we're starting off with a higher level question, and it's one that as an RBT, you're going to want to have some assistance with. Because when it comes to dealing with insurances and authorizations and that sort of thing, that's more of a BCBA task. But you are going to likely help write reports and generate charts and graphs and make decisions that are in the client's best interest. So if you have a client who's struggling in the last 30 minutes of 2-hour sessions, which isn't unusual depending on the time of day and the rest of their schedule, what should you do? What is the appropriate course of action as an RBT when you see something that you find concerning or something that needs to be addressed? A, push through since the insurance company determined the appropriate duration. Well, that may be true, but it also may be true where that authorization approves that long of a session, but maybe it's not needed. Regardless of what is and isn't approved by who and who not, we're always working in the client's best interest. And if this isn't in the client's best interest, something has to change. B, independently reduce session time to 90 minutes. Now, maybe that's an option, but that's not something or a decision you would make on your own as the RBT, right? You would have to go through a supervisor. C, discuss with your supervisor whether session duration or structure should be modified. Sure, if you find or notice this as an issue and you see this pattern, it's something you want to bring up. As the RBT, you're essential as a team member because you're with the client typically more than your supervisor. And you can see this type of thing and notice these patterns. D, increase reinforcement during the last 30 minutes to maintain performance. Again, possibly, but that is also something we're going to discuss with our supervisor. So if you notice a pattern like this or notice something concerning, get with your supervisor and as a team, discuss your next move. Your supervisor implements a new intervention for aggression on Monday. You notice that aggression actually increases during the first week. The supervisor explains this is expected and to continue implementation. What's the most likely explanation for continuing despite the initial increase? So think critically here, right? We have a situation where we're using a new intervention for aggression, and you see the aggression is increasing. Now, what might that tell us? If we charted that out and aggression was here, and then that first week it's going up, and then the supervisor says, we expect that and to continue. Why would they say that? What can cause behavior to increase from an intervention? A, the supervisor made an error in the intervention design. Well, since the supervisor said it's expected, it's unlikely this was an error. It seems as if the supervisor knew this was coming. B, some interventions may produce temporary increases before improvement. AKA what? Extinction, right? Extinction can cause this temporary increase, and then we get an extinction burst, and that behavior will trickle back down. C, increasing aggression always indicates ineffective intervention. Definitely not, right? That is much too strong of an answer. D, baseline data was collected incorrectly. Again, there's no sign that anything's been done wrong. In fact, the supervisor thinks things are going well, as expected, and they want implementation continued. Do we know we're using an extinction? No, but based on the information given, it is likely, and interventions like extinction that produce temporary increases are expected and indicate improvement. You need to identify potential reinforcers for a client with severe motor impairments who cannot reliably reach for or manipulate items. Standard multiple stimulus impaired stimulus assessments aren't feasible. How would you design a preference assessment for this client? All right, time to think again like a behavior analyst. You want to design a preference assessment. We know the client has severe motor impairments. They are unable to reach for or manipulate items, and multiple stimulus impaired assessments aren't feasible. So let's think about our choices. We have a single choice assessment where we're looking at one item, paired or forced choice, and in the question it says it's not feasible, that's out. Multiple stimulus, standard multiple stimulus, out. And then free operant where it's child-led. So really our only two options are single choice or free operant. So how would you design that? A, design a free operant observation in the natural environment. Well, given these motor impairments and they can't reach for or manipulate items, letting them guide is likely going to be more effective than even trying to present them with an item. They can't reach for, they can't manipulate the items. What are we going to learn from that? So a free operant where it's child-led seems like a better choice. B, skip the preference assessment and use edible since motor skills aren't required. We never want to assume reinforcement, right? Even something like edibles, we don't want to assume reinforcement. C, have caregivers complete questionnaires only since direct assessment isn't possible. Well, it's not possible, it's just more challenging, right? Questionnaires are great, we still need that direct assessment. D, use the forced choice assessment where the therapist moves items toward the client. The question said that's not possible, right? Parastimulus isn't feasible. So how would we design this? Likely a free operant observation where the child leads and we observe and take note of what they're engaging with. A client who previously demonstrated 90% accuracy or receptive identification of colors over several weeks is now performing at only 50% accuracy. The teaching procedures haven't changed. Before your next supervision meeting, what information will be most useful to gather? Let's think about this. You're coming up on a supervision meeting and you have to gather information about this client. They were at 90% accuracy for several weeks. That's very strong. And then they dropped to 50%. That's a pretty significant decrease. Nothing's changed as far as teaching goes. What should we learn? A, whether any changes have occurred in the client's life, medication, sleep, or other settings. If nothing weird we've done has changed as far as teaching and the plan, then we need to look at the environment. Has anything changed in the client's life? Because we were effective, now we're not. B, the names of all the colors the client is missing. That's not going to be all that important given they were at 90% accuracy. The important thing is why is there a massive drop? C, how other technicians are implementing the same program. Well, teaching procedures haven't changed and we're always using information given in the question. You've got to trust the information. D, whether the client's parents are practicing at home. Possibly, but that's more of this, right? A is just a more complete version of this. What's changed in the client's life? Is there other things going on? We haven't changed. Has anything changed with the client? A client hasn't eaten lunch and is very hungry. You present a cookie and say, what do you want? The client says cookie and you provide it. In this scenario, what is the hunger functioning as and what is the cookie functioning as? So the question is asking both about the hunger and the cookie. The client hasn't eaten and is very hungry. Let's stop there. When we're hungry, what is that indicating? It means we are deprived of food, right? We haven't gotten enough food. And deprivation is what? Deprivation is a motivating operation. It's increasing the value of food. In this case, you present the cookie and say, what do you want? The client says cookie and you provide it. What is the cookie doing? The cookie is now signaling reinforcement is available because it'll satiate their hunger. So, what is the hunger and what is the cookie? Hunger is the SD, cookie is the MO. Cookie is not the MO because cookie is not making you want hunger, right? Hunger is making you want the cookie. B, hunger is an MO that increases the value of food. The cookie is an SD. Yes, hunger has increased the value of cookie and cookie is signaling the availability of food. See, both hunger and the cookie are SDs. Well, you can be hungry, but if food isn't present, the cookie isn't present, there is no SD for that food. D, hunger is a reinforcer, the cookie is a punisher. Nope, they're both antecedents. They cannot be consequences. So, in this case, hunger is the motivating operation. It's increasing the value of food. Cookie signals food is available. Thanks for watching. Check out btexamreview.com for all of our study materials. When you pass your exam, let us know so we can include you in the Sunday shout-out. Work hard, study hard. We'll see you soon.